Hello, good afternoon. Welcome to our Better webinar series on the power of openEHR. My name is Richard Kavanagh. I've recently joined Better as the Head of Technology for UK and Ireland. And I'm very happy to have this opportunity today to host today's webinar on the technical capabilities of openEHR. So joining me today is my guest, Ian McNicol, Director of the openEHR Foundation Board. Ian has been involved in healthcare informatics for over 30 years and been working with openEHR for 15 plus years of that. Ian, hello. Thank you for sparing the time.
Hi, Richard. Thank you.
Before I hand over to Ian, just to let you know, we will be taking questions. So if you could type the questions in on the question box, and then we will deal with those at the end. So let's get going. Ian, take us into a deep dive of openEHR.
Okay, thanks very much, Richard. So I'm, in some respects, possibly the wrong person to be doing a technical dive into openEHR because I am a clinician by background, used to be a GP in the UK, but I have worked actually as in software development and part of my career. So regard me as possibly the most stupid developer that's ever lived on the face of the earth, and that's not a bad place to be when trying to understand a new paradigm. And I think this is the major problem that we have in healthcare, is just this challenge of digitizing healthcare. And very often I come across different countries in the world saying, oh, we do it terribly here and it's so much better in Estonia or in Canada or in Singapore. To be honest, it isn't. It is a universal challenge. So if you're struggling in your country, everybody's struggling in their countries. Of course, different countries have made progress in different ways, but this is a really, really challenging, difficult problem. Many, many different organizations, many different specialisms, many different applications, many, many different data stores. So it is just a fundamentally difficult problem, wicked problem that we're all trying to share, or we're all trying to solve. And one of the things I think it's worth thinking about and perhaps challenging, the phrase that I kind of grew up with was a clinical system. So as a working GP, I had a GP system. My colleagues in the hospital would have a hospital system. The social care people would have a social care system. Let's just dig into that a little bit, what people generally mean. What is in that? There are really three components. There's the user interface that people see and work with. There's the database, the actual data storage technology, and then there's the information model in the middle. And you could say that one of the real challenges is that what we have are 1,000,001 clinical systems all doing all of those jobs. So my GP system has its own UI. Now that's absolutely appropriate. It's appropriate that a hospital system has a different UI, but each has its own unique database structures and its own unique way of thinking about the data, the logical or information models, the business rules. And we have to question whether that's a sustainable approach for the future. It does involve huge amounts of knowledge capture from clinical people, huge amounts of technical endeavor to turn that into logical information models and then decide how to store it. And everybody is doing this again and again and again. And it's one of the major barriers for people when they're trying to bring a new EPR or clinical application to the market. And healthcare data management is really very challenging. The diagram on the right, it's obviously not visible, but you get the complexity. This is a real database architecture diagram from a hospital system in Germany, which is from some of our German colleagues. And you can see just how complex that is. And this is not a massive system by any means. It's a relatively small EPR. Healthcare data is very complex. Many different kinds of data types. Just as an example, every cancer is a separate disease and has its own record structures. So there's a huge amount of variance, and the whole thing is basically natively, it's a nested tree structure, which causes multiple unstable joins in RDMS type normalized structures. Clinicians like me decide that what seemed to be a single data point now has to be a multiple data point, or has to go from a single data point to a kind of cluster, sort of tree-like structure. So very, very difficult for people to sustain. And then, of course, there's just a huge lack of clinical standardization. Clinical records have largely been built as hobbyist systems. Even some of the largest in the world started as almost as one-man band clinical systems, and reflect the experience and the culture and the organization of the clinicians that help build them. And therefore, there's very little standardization across the piece. So I guess openEHR starts with two major aims. One is, can we reduce that data management burden? Can we just make it easier for people to build and manage data, not at the app layer, not at the UI layer, but at the data layer? And then can we definitely separate the apps from the data and start to organize the patient information, the primary patient information, into federated vendor-neutral data stores? There's a number of documents that you can see listed there, which start to point to this being a sort of future target architecture. And that means moving from what some people in Canada have called type 1 interoperability. So that's the traditional HL7, FHIR, CDA type interoperability, where each system manages its own data independently and then exchanges data between them, to something that some people have called type 2 interoperability, where increasingly the data management is offloaded from these different systems. It's shared data management with independent apps sitting on top of them. And that's one of the architectural principles behind the openEHR idea, which leads us to this open platform architecture. We've got the apps, which are not the business of openEHR at all, and then we have two layers underneath. We have this vendor neutral, hopefully is maximally shared information model that's freely shared across different applications and different organizations. And then at the bottom, we have a specialized technology neutral data store that we call a CDR, that underpins the technology and essentially replaces a simple database. So what is this openEHR Clinical Data Repository, or CDR? It's domain-driven no-code data store. By that, I mean that the ideas that are in there, the clinical ideas that are in there, come from clinical people. They are built and curated by clinicians and clinical informaticians like myself. And then they are applied or uploaded to these specialized data stores, but do not require any engineering. Not everybody likes the phrase no code, and I agree with that, but it's probably the best way of describing it. When I upload my new set of data models that I need to fulfill an application requirement, there's no requirement for me to speak to an engineer to change either the logical information models inside the system or the database structures. It is understood natively. I can store the data, retrieve the data, and query it via standard API. It's all standards-based and vendor neutral. It's technology neutral, so nobody says what kind of database you have to use. There are obviously database technologies in there under this CDR layer. But when you're working with this thing, you have no access to the underlying database. You don't ever work with tables. You never call SQL commands. Everything is done through the API. As I said before, there's this idea of no-code deployment of new content definitions. All of the data is completely available via the API, so there's no need to go directly into the whatever physical database is under there. And part of this is done through something called AQL, which means archetype query language, which allows for vendor neutral and indeed federated querying without recourse to direct database access.
Hi, Ian, just before we move on, so if we go back to the CDRs as a concept, I guess I have two questions. So one is, are they targeted at any kind of field of medicine? Are they equally applicable to primary care versus secondary care versus community care, mental health, or do they specialize in one particular area?
No, completely neutral. So I've personally been involved in building all of these social care systems, primary care, full GP record, hospital systems, registries, yeah, all of these things. The CDRs themselves are very neutral. We'll talk a little bit about the structures coming up, and you'll see that what's in the CDR, it's almost content-free from a clinical point of view. There's nothing that I would recognize as a clinician. They're generic structures. What they are, though, is focused around the patient. So anything that belongs in a patient record is appropriate to go in a CDR. If it's something to do with, let's say, demographics or resources, device management, equipment management, theatre scheduling, that's not part of the CDR. That would be held separately.
Thank you.
You had another question, or was
that
the two
questions?
questions?
So the second question, which I think you possibly almost answered, was really is any examples you have of systems that are using these CDRs out in the wild?
Yeah, so I'll split it into two broad areas. So I think the first tranche of systems that were developed using openEHR were mostly in the Nordics. And interestingly, this was not part of a grand open platform architecture. It was very much companies who they were well established in the market, but they felt they were getting really challenged to upgrade their systems over time. You know, they'd been doing this for some decades, and roughly every 10 years, we're having to do major, very, very major database upgrades and all of the hassle that is involved in migrating that data. So they really adopted openEHR as a better data management solution. Obviously built on some of the models we're going to talk about at the moment, but their primary drive was to provide a better way of doing essentially the same sort of thing, you know, traditional hospital systems or GP systems. The second tranche has very much been region or nationally driven, and that's just coming to the fore now. The most obvious one is Catalonia, which has decided to adopt openEHR right across, you know, a region of 5, 6, 7 million patients, and using openEHR as the bedrock for all of the systems that are going to be working in Catalonia. Now, clearly, that's likely to be a very long-term endeavor, but I'm certainly one of the people that think that this is probably the future of how we have to get everything working as if it was a seamless system across many different specialties and organizations.
Great, thank you.
So just to touch quickly on the domain modeling part. So as a technologist, if you're working in a tech, you don't actually have to understand some of this in huge detail, but it helps to understand the background. So openEHR has this idea of, we used to call it two-level modeling, but it's actually multi-level. So at the bottom, there is this technical specification. It's UML and UML-based descriptions. It's very, very stable. We're still at 1.10 after 20 years, and it's the kind of chassis, basic structures, data types, versioning, provenance, the outline record structure that you'll see in a moment. But there's nothing that you would see in there that you would consider to be a clinical idea. There's nothing in there about an allergy. There's nothing in there about a blood pressure. All of the clinical content is managed quite separately in a set of things called archetypes. These are built on the RM classes, but they're not directly connected to them. They're not subclasses in any pure object orientation. They're more like something that grafts on. I sometimes think the relationship is a bit like the way that CSS grafts on to the browser, document object model. They tag on to that reference model structure, but are managed quite separately. And that's where you start to see these sort of familiar components of the record: a blood pressure, a body weight, a medication order. And then we have templates, and these are essentially aggregations of archetypes for a specific use case. They're not forms. They can sometimes underpin forms, but there's not a one-to-one relationship between a form and a template. And they can be targets for data imports, like a lab test. They're not necessarily closely aligned to UI, but you can have things like a vital signs encounter, an end-of-life care plan. Critically, these are the technical artifacts that we upload to a CDR. So they are like when we've decided what data models we need to build, what templates we need to build, we then export these in an XML format using tooling and upload these to the CDR. So they're the kind of handoff between the clinical modeling world and the technical world. And it's the CDRs understand the templates and then can work with them from then on. So archetypes are these concrete clinical record components. open source, developed and managed by clinical informaticians, not really as technical artifacts. The screenshot on the right is one of the tools that we use. So we have an archetype designer tooling to build the archetypes and templates, but this is a CKM tool managed by the openEHR International, which allows us to get clinicians to look at, curate, review, and publish the archetypes so that they're designed to be fit for international use. Unlike, let's say, FHIR, which is quite sensibly decide to, let's just look at the 80-20 rule of the commonly exchanged data, because we have to be able to, essentially, we're working as the storage technology. We have to be able to handle anything that people want to store, not just the subset of things that they want to exchange. So we are slowly boiling that ocean of clinical record definition. And so these things are very much definitional as well as technical artifacts. The templates, this is where we pull a number of different archetype components. And this is an example from one of the projects we've worked on, which is the London Universal Care Plan. That archetype on the right, adverse advanced intervention information. That's something that was worked on and published internationally. And I think it's a really good example of the power of the openEHR publishing approach. So this is used to define the kind of data that you'd want to underpin somebody's CPR decision or maximum treatment plans. And I thought this would be very difficult to do internationally, because clearly there's a lot of, this is a deep and heavy subject and quite culturally nuanced, but we were able to get international agreement on the shape of this thing. And then this is now being used within the context of the London Universal Care Plan, part of which is around CPR decision. Do you want to be resuscitated or not? So on the left-hand side where you see that CPR heading, that's that archetype built into the template and shaped a little to cope with the some subtle variations that were needed in the UK area, mostly around some of the way things are described. That is now running, underpinning the end-of-life care records for 50,000 people in the London area, and it's now being expanded out, all built on openEHR. And we managed to do it within 7 months. And there's no way we could have built this without this kind of technology. Again, all of the models were built by myself and my colleagues, and we uploaded these into a better CDR, but there was no technological requirement after that. The better engineers did not have to be involved in shaping the data models or changing the data structures inside the CDR. So just before we dig a little bit deeper, this is one of the things that the openEHR RM defines. And this will become important when we start to look at the REST API, which we'll do in a second quite quickly, because one of the things that the RM defines is this very simple and, if you like, opinionated way of what an individual patient record should look like. So we've got the idea of an EHR at the top, and the EHR in this sense means the electronic health record for an individual patient. That can be subdivided into folders. Then we've got this idea of compositions. And the compositions are kind of like a document. The key thing about the compositions is that they are the unit of commit. So everything that is committed to an openEHR CDR is committed as a composition. Under that, within the composition, which is kind of just like a wrapper, the real payload is at the entry level. So you can see that idea of an entry. Examples are a blood pressure or pulse or general appearance. And then we've got elements, so we're down to leaf node elements, systolic of 120, diastolic of 80. We've little subtree elements we call clusters. Every single bit of data within an openEHR CDR has this shape. And how we define the archetypes is essentially by putting sort of cookie cutters on top of this generic bit and saying, this particular entry defines a blood pressure. Its name is blood pressure. It's got 2 elements in it, one called systolic, one called diastolic. They're actually coded, but you get the idea that we've got this very generic structure, and then we apply some extra rules on top of that. So what do you really need to know about that? The specifications are really deep, and one of the problems that we're battling with is to try to make the specifications a bit easier for people to navigate. So these are the parts of the spec that you really need to get your head around. And I'm saying that as somebody who's using an openEHR CDR. If you're building an openEHR CDR, that's a much more complex exercise, and you really need to dig deep. But I would absolutely urge anybody not to do that in the first instance. There's nothing to stop you doing it, but it's probably a 3 to 4 year exercise, even with a good technical team. There are many, many examples of CDRs out there in the market, some closed source and some open source, that you really should go to in the first instance and use them, work out how to use them. And of course, the majority of people are going to be consuming the data and working with a CDR that's there already. So these are the part of the specs that you should get to know. You don't need to get to know the archetype object model, which is really about tooling, archetype and template tooling. You don't need to know the demographics bit in the main, and other aspects like guide definition language and task planning are less commonly required. The thing you really want to get dug into is the openEHR REST API, because this is how you interact with the CDR. And I've put really the calls that you can see on the left-hand side are essentially all you need to know. So this is quite unlike something like a Fire REST API, where there's a lot of resources, and if you like concrete resources, domain resources like allergy or condition or device. We don't have that in openEHR. We have the definitions, but the REST API works at a different level. It works in terms of creating compositions and updating compositions and running queries. So if you get your head around these essentially 4 different types of call, you've actually got most of the way to work with openEHR. So it's not as complicated as you might think. So just going through these pretty quickly. Composition, all of the patient data is committed inside a composition object. The compositions also handle out of the box the who, when, where, and why context, who did it, who said it. It's all, the CDR will handle all the versioning. So if you need to update a composition that you've already stored, that's provided to you out of the box and pretty easy to manage through the API. There's a variety of serialization formats, which I'll talk about in a second. So here's a few examples. The original canonical API, the one to the right, is quite verbose. That is what was developed originally, and it's actually very close to the, if you like, the UML or reference model definitions, but better a few years ago, invented a couple of simpler formats that are called structured and flat, which are actually much easier to deal with. Critically, it all ends up in the same place in the CDR, so you're not compromising in any way, and you can store data as structured and flat and then bring it back as canonical if you need to. But I would suggest for most people, you either want to work with the structured or flat variations of this composition structure. And fundamentally, your job as a developer, let's say if you're working with a UI that needs to populate some data, what happens is that we give you an example composition. So the structure is already there, and you can see the hit points, like there's the respiration rate, respirations magnitude. And we would work with you to say, look, your respirations rate, that goes under that respirations rate magnitude. So it's all about hitting these points within a JSON structure, essentially. And whether you prefer the structure or the flat format partly depends on your background as a developer. We use the flat format a lot, and we found it pretty easy for people to get their head around, particularly if they're coming from an integration background. So that's what we used in the One London project to import data from the existing legacy application that we migrated the data from. Another key part, and probably the final key part, is the query. So you're not working with SQL when you're working with a CDR. So there is a query call, essentially a post that runs a textual AQL statement. So very similar to SQL in that sense, or it can be a stored AQL. And it returns a result set. So it's a structured JSON format that is defined by the AQL itself. It's path-based logical querying, so it's not physical querying. So you're not selecting from tables, you're not selecting columns, you're selecting paths from objects. And the AQL is flexible enough to give you full access to the whole data tree from that EHR object at the top all the way down to elements at the bottom. And AQL allows you to define whether you want to return sub-objects or scalars just by shaping the AQL. This is conceptually closer to Sparkle, the web query language, but it does have many familiar SQL terms. But one key extension is a contains clause that allows you to have wildcard matching of contained objects. So for instance, you can say, just give me any blood pressures that have been collected. I don't care which composition they were collected in. So building AQL essentially is about typing in text essentially, but there are some AQL building tools available. This is one that's in Better Studio, and it's keyed off the templates. So when we upload the templates, you can use those templates to help build the AQLs and return the data.
So Ian, just another quick question, if I may. So I'm just trying to look at those examples are a bit small, but all the AQL that I've seen, and it hasn't been much to be fair, has kind of focused around an individual EHR ID, an individual's EHR. Does it have to be, or could you query across the whole CDR as a whole to do like population scale queries or something like that?
Yes, absolutely. It's designed to, so there is a statement there which says from EHRE, and that is essentially open to make that apply to a single patient. You'd have to, as part of a where clause, or there's a different way of doing it, but part of the where clause, you'd have to say where their EHR ID equals 1, 2, 3, 4, 5, 6. So yes, population querying is definitely part of the scope. Having said that, often people still use traditional kind of ETL to do some queries, pull the data out into a more familiar SQL-like structure, which is easier for reporting, and it's more familiar for many people. Plus, it takes some of that heavy-duty population querying load off the CDR. But yes, absolutely. We use population querying regularly. Again, in the London example for reporting type data, or it could be used for cohorting, finding patients with particular conditions across a particular CDR. Great,
thanks.
So nearly done. I think the key thing, openEHR is not hard once you get the concept or concepts, and I think that one of the things that I find technical people find quite hard to lose is the fact that they're abstracted away from the database. They're abstracted away from the structures, and the fact that, in a sense, other people are defining the target information structures, and they're given essentially a JSON structure to work against. Once you get that idea, and the fact that the querying is not SQL-based, it's AQL-based, actually using the APIs is pretty simple. And if you get your head around the basic data types, the idea of compositions in these entry classes, you'll find yourself working pretty efficiently very quickly. Don't get lost in all of the somewhat obscure, occasionally openEHR specs, and sort of embrace this idea of domain-driven deployment, where it's someone else's job to get the data models together, which can be quite challenging. I've also put a few little resource links there. Better provide a sandbox CDR. We've built a little Postman collection that will work against that CDR, but with others, including the Airscape and others, so Airbase and others that are out there. Another great little resource is put together by my colleague Siddharth Ramesh, MedBlocks, well worth having a look at that if you're just getting started. And that's me done.
Great, that's really good. I mean, just another resource maybe that we can circulate afterwards is I found working in various standards communities, the actual community itself is a really valuable asset. And just as people are maybe not aware, but there is openEHR UK. It is a community that's there to help people and promote openEHR and more than happy to deal with them. And there is an openEHR forum online which people can register with and pose questions. It's a very friendly place. I know that I've asked some stupid questions there and I got really good feedback. So that's really good. So I believe we have some questions. Let me just go here. Okay. So I'm going to butcher this name, but I'll have a go. So the first question is from Fabian Franzek. Hopefully I've said that right. So his question is, how do you manage governance for the modeling within an institution? So I guess when you develop your own archetypes and templates, you need to manage the modeling as well.
Yep, it's a great question. I'm actually looking at, there's a further question from Anton further down, which I think I'll answer them both at the same time, because I think they're both directly related and essentially about governance. Yeah, governance becomes king. So, you know, in a sense, again, just I'm drawing comparisons with HL7 Fire. This is not a criticism of either, but I think it's worth drawing the comparison. So in HL7 Fire, essentially, you know, a lot of the models are, in a sense, more part of that fixed reference model. Although you can see, because we've gone from Fire 1 through now to Fire 6, you've got to expect these things to change over time. So openEHR has taken a different approach, which is to say there is a very small fixed part of this information model, but the rest of it is governed much more like open source. And in particular, the clinical parts are modeled independently, and each archetype has its own governance cycle. So we don't have, you know, sets of archetypes that are updated at the same time. They go through revisions and change their versions over time. We probably don't have time to go through the, you know, the whys and wherefores of that, but I still think where you've got the task of working, you know, with the job is to support people who are building systems, not primarily about everything lining up for exchange. I think it makes sense to have a different governance model. But it does mean you have to govern things very tightly within your institution, right? So again, it's much more like building software. You would not expect to rely on the international repositories to be your source of truth, because they will continually update in their own time. So you have to take a local copy and manage that very tightly, and then feed in updates into that local library as and when it makes sense. I think one of the big changes, or one of the big values we will see coming up, is the ability to get much, you know, tooling that will help us in that process. There are already some helpful tools, both in the CKM tool that we use internationally, both in Better's Archetype Designer, that lets us do comparisons across different repositories of which versions are there. But yes, fundamentally, you as an institution or as an application builder, if you've got your own CDR and are building against that, you have to manage those artifacts very tightly and the relationships and versions between them.
Okay, so we have another question. This is like, who's your favorite child? You know, so what's your favorite archetype and why?
The favorite one is the one I showed, that advanced intervention decision, because you know, A, we got it published, but B, it's such a culturally awkward place. You know, the whole idea of you know, do not resuscitate decision. We know there are parts of the world where, for cultural, religious reasons, that will not be, you know, popular or acceptable. So I foresaw all sorts of problems. That is my favorite one. The favorite one that we haven't actually published is one that we talked about called Nota Bene, which is kind of an alert. It's an old clinical name, and we thought it'd be quite fun to publish one in Latin as a primary archetype in Latin, but we never quite got around to it.
That's great. Next question. Wait, of you have a question. After trying to build some templates, I find there are concepts which are in a grey area between admin and clinical. How do you handle this?
Yeah, you'll find grey areas all over. You know, I've been doing this modeling for 15 years, and I'm still astonished at how hard I find it, you know, because we're always finding grey areas and different things. I would honestly say, post it on Discourse. So openEHR Discourse, which you'll find easily enough just through Google, is a great resource for that type of question. Just post what you've got, give an example, and you will find people will reply. And you may find there's a bit of a debate about it, because these things often aren't clear cut. So yeah, please broaden that conversation, and we'll get some replies for you on Discourse.
Okay, so next question. Oh dear. So this one's come from John Farrington. So any operational examples of multi-platform, e.g. regional federated implementations? So for example, London UCP and Ambridge UCP, could you query both concurrently?
Yes, so there is a historical example, also in London, an older project around genomic, they were really phenotypic repositories. So I think there were at one point 14 hospitals in the London region that were storing some data, and these were being queried in a federated way. More recently, there's an active group led by EY who are building some standards and proposals around how we can do this. So again, yeah, it's going to be about standardizing the archetypes and templates across the federations, standardizing the AQLs. So yeah, building the rules of the road. So it is technically possible. Again, it probably comes back to a governance challenge rather than a technical one, to make sure that everybody is lined up, but allows some wiggle room for different institutions to do things a little bit differently.
Great. So this one's from Kopshini. I hope I pronounced that right. So what are the major barriers to adopting openEHR? How have these been overcome in projects that have been adopted for openEHR? So, for example, in Catalonia.
Oh, that's a big question. I think this idea that we can separate the apps from the data rather than leaving it in the hands of, if you like, legacy EPRs and trying to connect them all. That's a big idea. That is, it requires political level energy really to get that going. We're starting to see that in the UK at regional level. It's still hard, so for instance, Scotland and Wales have adopted openEHR strategies, harder in a bigger country like England. So I think that requires a pretty big and brave, regional or national energy to get that going. Although, of course, there are a number of different just companies that have adopted it, Better being one of them, but also 4 or 5 others across the Nordics who have said, look, this is just a better technical solution for us. Leave aside the big open platform idea. So yeah, I think we're starting to break down those barriers quite quickly now, and we're starting to see a lot of energy across Europe, particularly.
Perfect. So this one's from Kenneth Harden. So it says, if the data is not coded, how is the difference between diabetes and probably not diabetes made?
Kenneth, that is a name from my past. I know who exactly this chap is. Kenneth, good to hear from you. The data is coded. We probably didn't make that clear. My little example, I was just trying to make it clear of the structure. We would absolutely, everything is coded in openEHR. So where you see systolic, there is actually a little code sitting behind that gives it accuracy. And obviously we'd make use of coding systems like SNOMED for the results of a problem diagnosis. We also explicitly separate out things like meningitis excluded, or probably not diabetes. We would call these negations, and we actually store them in a different structure. We don't try to have diabetes no. We would say that's a different thing, because it's very easy to get your querying mixed up if you forget to exclude the no part.
Yeah, so I just think because I got confused about this when I was delving into openEHR a while ago. So there's coding on the data element to say what the data element is, but also can be coding in the value of that data element as well. So yeah. So the coding of a data element is kind of dictated by openEHR, whereas the coding in the value of that data element can be anything you like. It could be SNOMED, it could be DM+D, it could be anything.
Yeah, we can also, it has, where, so in a blood pressure, the systolic has its own internal code, which tells openEHR what it is. It says this is a systolic blood pressure. It also allows us to internationalize these archetypes. So they've been translated into many, many different languages, and you can query independently of language. So it will have a little internal code, something like AT002. Don't worry about that. But when you're querying, you're generally querying on that internal code. But we can bind that to a SNOMED or LOINC code. So if people want to do querying and say, use the SNOMED code to query on that, we can do that as well.
That's great. So this one from Simon Neubauer. Does the API support aggregates like counts and etc.? So if I want to count patients with attributes X, do I receive a result of all patients with this filter, or can I get the aggregated result? So can you do it in one hit, or do you have to get the data and do it yourself?
No, you can. So it is a subset of what you'd find in SQL, and it varies. The actual implementations of this part of EQL do vary between the different CDR vendors. Better's is probably the richest one at the moment, and I'm pretty sure they can do count sum. There's also some grouping functions, etc. So the answer is yes. It won't be as extensive as what you might find in a typical SQL implementation, though. But the big ticket items like count and sum, I'm pretty sure are supported.
Great. So that kind of brings us to the end. First of all, thank you, Ian. Thank you for your time and sharing the wealth of knowledge that you've got on openEHR. I think, well, I hope that we've explained, so some of the technical detail on openEHR. Clearly, you can go a lot deeper had we had more time. But no, we should have had a good start for this whole sort of revolutionary approach to healthcare data management. And so for our audience, thank you for joining us here today and for expressing your interest in openEHR. You can find all the relevant information connected to this webinar and the series on our webpage, and it will be shared via various social media channels. And you'll see on screen at the moment, there's a QR code. If you could, please scan that QR code and we get a feedback form, a survey that you can fill in, and that will help us to improve these webinars as we go forward and in the rest of the series. So thank you once again for joining us, and we will be back with our next webinar in the series. And the next topic is medication management in the case of electronic prescriptions or the EPS service. We hope to see you then. Have a nice day. Goodbye.